Hello, everyone. I'm Robert Dempsey, and on behalf of the Department of Neurological Surgery, we're doing a update on the COVID crisis. And particularly today, we're not only updating the crisis, but we're talking about this concept of opening up the department, opening up the medical facility, opening up the country, the world. That's a very big change, and it's worth talking about a little bit because when this all started, there was so much uncertainty, inability to tell what the disease, who had the disease, how to test for it. There's so much uncertainty and fear that it really dominated our approach. What we have now is a really different situation of relative calmness compared to then, and a little bit more confidence for us to be talking about opening up. I'm going to argue that that's because of two things, science and people, and equal amounts worldwide. And what that means is a progress now which sounds haphazard, but I think will be dictated by just the realities of the world of opening things up because we need to and because we have to follow certain processes if we have any hope of it making sense. There are many agencies that are trying to regulate this. I suspect it'll be regulated by the people who will vote with their feet as to what they do and what they feel is safe. So it'd be important to understand the background behind that. To really start to think about what does it mean to open up? What is that? Where does that put us? Well, the first thing to understand is that we're dealing with this villain. This is an invisible one, kind of rare. I mean, usually when whole nations or worlds have to mobilize, they mobilize in war, and that's what it's been characterized as, probably incorrectly, because this idea of pestilence, famine, disease is older than war and much more effective. But an invisible enemy that was fought to a draw, at least in Dane County, by people. And the people are everybody. They're the people who kept it clean, the people who made the food, the first responders, absolutely the nurses, minor account the doctors, but the staff, and the scientists. I think they need a lot of credit. We talked about the difference between where we were 3 months ago, not knowing who had this disease or not. There was not an available test. And our own scientists said, we'll go and develop one, and did. Remarkable, really remarkable. And now we can routinely test almost anybody with varying degrees of accuracy. But that ability to test allows us to really, for the first time, begin to use techniques that are not draconian isolation, but rather focused on isolating the disease as opposed to everyone. And that's really going to be the secret to opening up. If we begin to think about those components, a lot of it begins to make sense. Now, there's a lot of stuff we've learned from the science over the last 3 months, and there are important modifications about what we said early. Early on, we described this idea of a virus as something that can be very specific to the cell it attacks. And indeed, there's a range, otherwise it wouldn't jump from species to species. This particular novel COVID virus is not like some in only attacking leaves. There are probably millions, if not billions of viruses. We only know 6,000 to 7,000 of them, but they attack lots of living cells and try to take over its mechanism. This one is really good at respiratory epithelium of humans. Not so much other creatures. I think one example of a dog, some cats, certainly bats. But from our standpoint, we're learning, the scientists tell us that it isn't exclusive to just respiratory. And therefore, if we just test respiratory, we may miss people that are infected when this is affecting their vessels or other organs. And we were hoping, of course, that some viruses are very specific to their temperature. Some are only in winter. This started in the winter. That was a hope. But we knew it wouldn't be true because we knew that it was not specific to any latitude. And right now it's sweeping across the equator throughout South America and entering both Africa and Asia at the equatorial levels. That's very serious. It's what the 1918 pandemic did, but it's not something that the last coronavirus, SARS, could do. So this is different, in some ways more dangerous, but we have to allow for that. The scientists also began to tell us that the difference is very definite between what organs it attacks. We found out, for example, that it preferred respiratory cells. That's true. Others, not this ones, like rabies and polio, the central nervous system, but this one seems to also, by its immune response, attack vessels. And that probably explains the increase in strokes, the increase in cardiac events, kidney events, and the famous COVID toes that the children are having. So they're getting this virus, but not so much in their lungs. And therefore, their presentation and our understanding of it has to be different. The major difference here is the immune response. If a virus is not very effective at attacking you and your immune system quietly removes it, you never even know you had it. Those are the asymptomatics. If, however, the response or the battle that takes place is an antibody and your immune cells try to remove this invader, it can actually be fatal. The immune response can overcome people. That's absolutely what happened in 1918 when people's lungs filled with fluids within 24 hours. That wasn't the bug, that was the response to it. And that's what we're seeing in these vascular events. And these can occur late, a late antibody response, which basically attacks the host. And that's the sort of symptoms that you see with Guillain-Barré and the sort of concern that this has as an immune system. And that's the cautionary tale that I said about vaccines. Vaccines have to be just right, not too much, not too little. But we know that convalescent serum, just getting the antibodies without making more, is being a successful treatment. And the differences too from the scientists compared to other pandemics in the past has been real. We're beginning to understand by treating the symptoms, oxygenating the lungs, clearing the immune response, we're saving far more people than we did even 2 months ago. In other words, in this hospital, if you come in with coronavirus, you're likely to go home alive and well. If you did that in Milan 3 months ago, you'd be dead. And so just the common sense ICU makes sense. We understand that the real protection is don't let someone sneeze and cough on you, hence the mask and face shields. Wash your hands, wash your hands, wash your hands. It does stay on surfaces, but not as long as we originally thought, which is optimistic. And this avoiding direct contact seems to be the real key. So that's important. So when you have a situation where you don't have a cure and you don't yet have a vaccine, what do? Well, first you try to set up a system where it can't find new vectors. There are two ways to do this. Isolate either all people or the virus, or let everybody get sick. Many will die, the ones that don't may be immune. Well, if the second appeals to you, I don't want you in my hospital. I don't want you on my team. But some people have advocated that strategy, and it's a very poor one because of the amount of effects on all people of all ages of these viruses. So we affected with the inability to test an isolation strategy, which meant we just isolate ourselves. Now, it doesn't take long to realize that life, economy doesn't do well with that. With strict isolation, nobody's working, there are no jobs. This has happened before, and what follows is recession, depression, famine, illness, and war. So the isolation strategy should really be isolate the virus. That is, test and isolate, find out who has it before they start spreading, isolate them and their contacts, treat them, the virus will die out. The other strategies, the virus mutates and loses infectivity or its virulence. That'd be great. It happens sometimes. It has happened in our lifetimes with some, such as that original SARS, but it's not showing signs of doing that here. And indeed, while the 1918 pandemic did mutate and die out, it took a year and a half and 100 million dead. Now, right now, we're at a position where we're looking at hundreds of thousands of dead. We don't want to be getting into 100 million. The effective vaccine is the key, but not all viruses have been effectively eliminated by a vaccine. We're trying to pull a polio or measles, and indeed, if this is AIDS or Ebola, we will not have an effective vaccine. So we have to go very hard on this idea of isolating the disease and using the lessons we've learned here in the hospital about how to do that. So what's the effect been worldwide? Well, it's profound. We're over 5 million that have been known to be infected. Now that is nowhere near the real number. It's probably twice that. The epidemiologist will tell us years from now what it actually was. Indeed, as is often true, it becomes politically unwise for certain people to advertise the number of people that are sick under their care because it will make them unpopular. During World War I, it was a strategic imperative not to let the enemy know how sick your country was. So underreporting of pandemics is common. However, we do know that the effects are great, and yet there's some very important data that we're seeing. This is a hotspot disease. There are large areas that do well, and the medical system is not overwhelmed there. We need to recreate that. Right now, in the United States, our numbers are kind of stable, but not everywhere. We are trying to open up the country because it's kind of stable in a pace that we're able to maintain healthcare. However, you have to remember, if people aren't working, if they don't have jobs or food, if they don't see their doctors, this will much worsen. All the other conditions will worsen. Hence the desire to, quote, open up the health system and indeed the economy, because absent that, trouble happens. Unfortunately, the disease is quite evident worldwide. In areas that had no disease 2 months ago at the equator are now the hotspots. After the United States, the number 2 country in the world is now Brazil, mainly because it ignored this disease early on. Its neighbors, Peru, Chile, Ecuador, lead the world in infections per capita, meaning that this is a true hotspot now. And will this sweep across the equator through Africa and Southern Asia is yet to be seen, but is a concern, unless we are able to maintain this idea of isolating the virus. It's probably not possible in some parts of the world, refugee camps, etc. That's why this is an area of great concern. But think about the economy, think about the impact. We know that basically the UW and its hospital and its system requires to keep working. It cannot simply continue without doing its job. And so it's trying to open up safely. It's no different with the world or any other industry, but we will be profoundly changed because we've learned that we are not ready to travel. And any government can say anything they want about going back to normal. If you don't feel safe in traveling, getting on a plane, flying to India to see the Taj Mahal, you're not going to do it. And their tourism income will be lost. This will go on for some time before people gain their confidence. So this process of opening up must make sense in a world that is talking a new language of furloughs and capital projects at the hospitals. They've been changed and they've been changed forever. However, we have, as a local institution, done a very good job of isolating the virus and of common sense in our populace and of living next to a monster hospital that's been able to protect us, so that we are in a position where we can carefully open up and try to model that in our society. And how do we do that? Well, we look at what we've done to get here. We spent a lot of time protecting our patients, and we need to make sure they know it's safe to go see your doctor, to have that chest pain looked at, to have that numbness in the extremities seen, to have that well baby care, or to have that cancer exam. We've learned how to protect our team, masks and face shields, and we learned we don't forget that and just get tolerant or cocky. We cannot do that. We learned that we're going to be taking care of COVID-19 for a while, probably more than a year. Beyond that, no one knows. My hope is that it will slowly disappear, be isolated, contained, and perhaps vaccinated away. But until it does, we have a lot of work to do, and that's what we'll be doing. And each of us has played a role in that, a mission. And so as we open up, we're going to recreate what we're doing as we come to normal. Clinics, for example, will open up in stages and are already doing it. Unbeknownst to a lot of administrators, we're at 90% in our clinics because we're using new technology, telehealth. The ORs are approximately 80% now and can go higher, I believe 90 shortly. But we are mostly taking care of the people from the last 3 months who have been backlogged. We need people to know that they can see their doctors, their primary doctors, and care. We need to get our research restarted. We need education restarted. And to do that, we follow the lessons that we've learned. And that's a strategy of threes, because when you look at advice as to how to open up, I'm sorry, but it's too contradictory. You look at our government, there's a concern of who's in charge. According to the federal, the Supreme Court, the state Supreme Court, the governor, the state legislature, the local, each has changed responsibility depending on really their own position of strength or weakness. So who's in charge there is a concern. UW, who we work for, are really multiple groups. UW, the university, UW, the medical school, UW, the health and neurosurgery, the department. But all of them, if you really look at it, are going to follow a very similar course of opening up. And that's just common sense. That's the reality of the world. Because we can now test and tell who's sick and who's not, and we can screen who's sick and who's not, we're going to open up our society, our school, our department, our research, our clinics, our med school in stages. Each has really logically come in 3 stages. Now, they've called them 1, 2, and 3. I call them May, June, and July. Because the goal is to go from about 20% of normal activity. In some places like the labs, it was probably 15%. In some places like the ORs, it was 60%, 30 for a brief while, but then 60. In some like the clinics, it was 20%. To go to 30, 60, and about 70% of normal by July. And that's the goal that everyone has said. They may put it in different words, but that's really what it amounts to. And in each example, we're beginning to get instructions that exactly follow that. The labs today received word that yes, they should open up, but they should strictly follow the lessons learned in the hospital about personal protective equipment, about spacing, about separation, and testing if there's any question about illness, disease, or contact with illness. And that must be certified through the university and through the department and through the med school. Each lab will have to do that, and Dr. Venmanganti will be distributing those instructions, which arrived today. It's exactly what was expected. It's exactly what we prepared for. It will work. because we can do that if all the other labs, the vivarium, et cetera, open up in lockstep. The clinics already have taken that by using the telehealth, and we're well above the 70. So each May, June, and July comes differently. But our general clinics, our regional clinics need to follow the same rules, the same opening up. I think we are extraordinarily lucky because we are a medical institution. We're good at this, we know it. But I worry about our restaurants, gyms, stores, concerts, sports, because some of their business models cannot survive that. If you've ever been involved in a restaurant, you know that their business model really requires them to be above 90% capacity if they really want to survive. And very few of them have the space to space people properly. Unless we take advantage of the good weather and we do outdoor seating, etc., a lot of these restaurants may not survive, although they will try. Gymnasiums, etc., it depends on the exact sport and concert. I doubt that we'll be seeing masses of people crowded together for concerts for some time, but we will have to look electronically and other ways at our entertainment. Sports, I believe, will participate and will participate this summer, but usually to televised audiences or carefully computer-spaced use of large stadiums. But be careful because most of sports requires ticket sales. And absent those ticket sales, most amateur or small colleges will disappear. The large ones that have large TV contracts, pro basketball, they'll do better. But if you look at, say, football, some 2/3 of the income for a college is from ticket sales. Now, pro football, about 40%. It's a lot, and so they're going to have trouble with their business model. That's going to be a problem for society. And if society is down, then you're looking at a recession or depression. And so what we have to do is to not allow a resurgence of the disease in this region as we open up. We have to be sensible. And I actually have great faith in people. I know that 20% of the people are going to act out and they're going to crowd the beaches, etc. And we're going to have to take care of them. But I feel that the majority of people are going to, at least in this region, obey the rules that kept them safe and keep us safe. And that's really the secret, because if we do that, we will succeed. And we will succeed in our jobs because all of you are essential. All of you working at home will gradually, 30%, 60%, 70% be working in the offices, but not all day, because you can do your base work and then do the rest from your computer at home. We will be doing more of that. Life has changed. And that's a good thing, I think. We learned of it. And we are much luckier than these other types of work because some of their models will not work until this disease is gone. So we have to keep society going. So what is going to be the normal that we get back to? Well, we're doing well, but it's going to be forever changed. We decrease the infections, but we spread out the duration. And that means we're going to be very much looking at ourselves, our families, and the land around us, which we're blessed with a very rich, beautiful state to live and work in and to maintain our physical and mental health. But we have to do more than that because it isn't just about us, it's about everybody else. We have a responsibility for each other. The nurses who take care of each other with this magnificent way to keep their PPE. My daughter who works while doing her work online, goes shopping for all the elderly people in the neighborhood. It's the way we keep in touch. It might be human touch in months. I certainly hope so, but right now it's electronic, it's food, it's messages, and that's important. That's essential. We keep doing that because we're proud of people. We have to take care of our own personal health because we're no good to other people in healthcare if we're ill. We have to exercise, and there's no nicer place to do it than outside in Wisconsin when the leaves are on the trees. We do our best And that's all we can ask. We're in it together. We're very lucky to be as well prepared. We're very lucky to be sensible. We are opening up our society, but the microcosm of it, we're opening up our department, our medical school, our hospital by basic rules that we established to get through the last 3 months. We'll protect our patients and ourselves with our protective equipment. We'll space, we'll separate, we'll try to isolate by contacts and by symptoms and disease, and protect the patients of all types, be they cancer or COVID, stroke, or well-born newborn child. And remember what my Swahili friends told me, that when man makes plans, the gods are laughing. So we will change. We can only predict that we are in a better place than we were a few months ago. And we've got through it because we did it together. And I'm immensely proud of everybody. And we will get through and open up and get back to a new normal, different but productive, because what you do at the medical center is important. And you're very lucky to be doing things that are important and have value. And so I've learned a lot from this. I've learned to be proud of the people I work with, the staff, the cleaning crews, the engineers, the scientists, the people that really made it work. I want to particularly thank the patients. I want to particularly thank the nurses. Their companionship, their working together are why the sun rises in our east and sets in our west. So we are opening up. It's going to work gradually. And if we can avoid a surge of COVID patients, it'll work successfully. And we'll be here and we'll be helping people now and into the future sequentially through the summer. So take care of yourselves, and thanks for all you do.